So we're winding down. We have a QA period of time here for you to ask questions, ideally related to these talks, but everything's open. I'm going to start with one for Dr. Yu. This is related to Axumin scans or potentially any PET scans. If you've already had one scan, is it possible to get additional scans, and are there insurance issues, and how do you get reimbursed? These imaging studies are pretty expensive.
Yeah. So, let me use a microphone.
Oh, sorry.
Yeah. Hello? Okay, yeah, you can hear me. So, yes, we have many patients that you get one Axumin, and what we're standardly doing is using 0.5 as the lowest level where we start to think about getting an Axumin scan. If that first scan doesn't show anything, we'll oftentimes try again around 2 and maybe around 5 again. That being said and done, in certain patients, I haven't run into insurance issues. In other patients, right off the bat, we can run into insurance issues, where the insurance company right off the bat will say, no, this is not something that we will cover. And many companies have come and created their own guidelines. I've seen this from a few companies, and they say PSA must be above 1 or PSA must be above 2. I've started seeing all these things. In those situations, I've done peer-to-peer, and you have to sit on the phone and wait and on hold and talk to people. Oftentimes you're successful. Once in a while you're not. So I will say that although this is FDA approved, I think it could be considered a very reasonable standard of care scan. But at this point in time, I can't say that every insurance company is covering it. But we do have to be thoughtful about it. I don't think that these approaches of finding the cancer and trying to treat it with surgery or radiation is right for everyone. There are clearly situations where we could, if we're not careful, do more harm than good, and we have to be very thoughtful about this.
Great. There might have been a minor point on one of your slides, Evan, that one of them appeared to show a negative PSA. I think maybe you're showing a percent change or something.
That was all percent change. Yeah, it wasn't a negative PSA. It was percent change baseline.
There is no less than 0.
Right, no, good point. Yeah. Good point. Yeah. No, the 0 is basically baseline is 0%, and then it's either increased percentage or decrease. That's where all those waterfall plots meant. Sorry about that. I should explain that better.
So we're missing our urologists, who probably are more appropriate for this question, but Bruce or Evan may want to address it, and that is focal laser ablation. There's lots of discussion about focal therapy in prostate cancer. Usually we're talking about that for prostate cancers that are still in the prostate, as opposed to trying to use HIFU or high-frequency ultrasound or something for metastasis. So I think this question is probably more related to the local disease. And the question is, for breast cancer, we do lumpectomies, for example. Why don't we do that in prostate cancer, right?
I'll take a stab at it. So I think, again, not relative to metastases on these PET imaging studies, but relative to exactly what Dr. Nelson says, for primary therapy of the prostate cancer that is felt not to spread, for those with really localized prostate cancers to certain areas and lower risk features, it is a very active area of investigation, and it is being done at certain places and being investigated as well. But it's still an early field right now, but I certainly think it is interesting and worth exploring.
So probably either of you could address this. For the PSMA lutetium treatment, are there still issues with the salivary glands, or is there a workaround for this side effect?
Yeah, okay, that's a really good question. It's a very sophisticated question. So some of the side effects that have been seen in the early studies include things like suppressing the blood counts, the bone marrow, white blood cell counts, red blood cell counts, platelets. That's one potential side effect. Other things that have been seen have been infiltration of the tracer into the salivary glands, because it can be uptaken there, and it leads to basically a lack of production of saliva, which can be very uncomfortable, and artificial saliva is just not so pleasant. So understandably so, you can get it, but it's not very pleasant. Other things that have been seen is it can get into the renal tubules, the kidney tubules as well, and potentially cause damage there. So it depends on the radiotracer. Okay, and it depends upon the targeting agent, because if you think about these compounds, there's really a couple components. One that binds to the protein, that's found on the cancer cell. And that can be an antibody or small molecules I've talked about. And the other is what's the actual radioactive agent? There's different ones. So what we've seen are if you use an antibody, it's a bigger molecule. It hangs around the circulation longer. You don't see as much penetration into the salivary glands, but you can see more suppression of the blood counts. Okay? If you use an alpha emitter, rather than a beta emitter radiopharmaceutical, the alpha emitters can have much more potent toxicity and kill. It's more focal, but it can be much more potent, and that can cause more salivary damage as well. So it's a very active field right now where some of the studies are moving towards away from the antibodies, using the small molecules. But if you're going to start using these alpha emitters, which are different than lutetium, as we talked about, there's a drug called a radiotracer called actinium, or one called thorium. Maybe combining with an antibody makes more sense. It does less damage to the salivary gland. So long answer, sorry about that. Happy to talk more about that afterwards.
So relating to PSMA, and I think this question is more around radiation therapy. So we often give androgen deprivation treatment along with radiation therapy, and that's for a fixed duration. It's not forever, it's stopped. So the question is it a good idea to get a PSMA scan as a baseline after androgen deprivation therapy has ended relative to future metastases? Is that a time to get a baseline?
I probably wouldn't, because in that situation, PSA is a really good biomarker, right? I mean, PSA is really good. Even though PSMA PET might look like the most sensitive imaging modality, it's still not quite as sensitive as PSA. So that being said and done, I think PSA is probably your best marker there.
So we had a couple of other questions. I'm just going to read the question and try to respond. So one was more discussion about identified problems with BRCA1 or 2 that is damaged. What can be done to help the body stimulate healing? I think I may be misinterpreting this, but I'm interpreting this as, for example, somebody who has this as part of their normal DNA, which is present, if people inherit an abnormal BRCA gene, every cell in their body has an impaired ability to repair DNA damage. So in those folks that are at a higher risk for developing cancers, such as prostate cancer, and in women, breast and ovarian cancer, so I'm interpreting this as, can we reverse this risk by somehow repairing the BRCA capacity to take care of DNA damage? As things stand today, the short answer is no. Clearly, there's a lot of genetic engineering that is going on. I'm not sure that we'll ever be able to actually, in an adult, reverse all of that risk that goes along with that, but with the idea in mind that, for example, families that are BRCA positive, they're carriers, being able to, we're not there yet, but engineer the situation such that the offspring would not be at risk, I think is something that people are working on. And then there was a second question that says, can DNA repair be used for asthma? I think obviously DNA damage is part of a lot of different pathologic processes. I'm not aware that in asthma the DNA damage component of that is the primary driver of that disease. So I'm not aware that we can leverage that for asthma, but if either of you are aware of some aspect of the pathophysiology there. So the short answer is, unfortunately, I don't think so.
Okay, I'm going to spend just 5 minutes in closing. I want to thank these two speakers for